You're listening to the Diagnosed podcast, where every diagnosis has a story, and every story deserves to be heard. From survivors to loved ones, we explore the journey together with your host, Albano.
So what I'm going to do then is for the people who haven't seen the first episode, because this is the second time that you've been on the show, and the first time was quite interesting because we went through a whole range. After we got through the discussion of some MMA stuff, we we got into quite a few details on health and nutrition and exercise, etc. So if anybody hasn't seen that, that would be a great precursor to what's going to be coming up right now, which I'm excited about. But before we do that, I'm actually going to reintroduce you. So we're with Dr. Samir Seif, and he's a doctor of botanical medicine, doctor of osteopathy, clinical nutritionist, and naturopath. And I'm sure there's a few other things in there that I probably missed. Some people know you as the Sandman in your fighting days. But at the end of that first discussion that we had, the conversation got away from us real quick, where before you know it, time's just gone, and it would have been nice to sit there for another 15 hours and just go through a whole bunch of stuff. But at the end of it, you had a few things that you wanted to get into on your end, so we're just gonna continue that conversation. And I'm pretty sure that you wanted to talk about vitamins and minerals specifically. So there's a few things around there that you wanted to get into.
Yeah, I want to. Well, it's first off, I want to explain for your audience the lens at which I'm coming from, how I look at medicine. We call it natural medicine, and the difference between osteopathy and allopathy, or modern medicine, allopathy, is I want you to think of medicine without the pharmaceuticals, without the industrialized pharmaceuticals and surgery. So if you've done the pharmaceuticals, you've done everything you possibly can, you've done the surgeries, or you want to avoid pharmaceuticals and surgeries, then you come to a person like me. So that's what I'm practicing, is trying to find the source of the illness, find the source of the dysfunction in a system of systems approach, holistically look at the body. But if you're trying to figure out what's botanical medicine, what's osteopathy, think of medicine without a pharmaceutical. We would do it with plants, food, nutrition, natural compounds, and we would do it with exercise, mobility, but we would try to do it without surgery and without like toxic levels of medication. And then if that didn't work and you needed acute care, then I'm in behind supporting. So when you have some pretty severe protocols that are highly toxic, like say, for example, you have to do chemotherapy and you have no choice, well, there's going to be a lot of payment, a lot of cost when that happens. And we would look to nutrients, botanicals, vitamins, and minerals. So that's what I was really excited to have today, an opportunity to express natural medicine without any negativity to modern medicine. That's not hopefully what this discussion will be. It will be in terms of we've got modern medicine and it saves lives. And anyone that bad mouths modern medicine, they don't know what they're talking about, because people's lives are saved every day, all the time.
Yeah. So you're not looking at it as an either or. You're looking as these two approaches as complementing each other.
Absolutely. Yes. But what I'm also looking for is, see, on the side of, like, it's different for me in the clinic I work. I'm in an environment where I have been embraced by allopathic medicine, by people that are prescribing pharmaceuticals, that are directing surgeries. But they want me involved, right? But where normally that's not the environment. So it's always like, in my opinion, a one-way street where I'm like embracing all forms of treatment and medicine, to get the end result, which is someone, keep them alive, keep them vibrant, keep them healthy, keep them going on. Whereas it's not really reciprocated, where we're kind of on the edge. We're still on the edge, where I'm getting severe cases that I literally fix with a vitamin or mineral, or movement. Like, at sometimes it's just not rocket science. It's really straightforward chemistry, biology. And that's what's occurred now. More and more, I have been delving very deeply in what we call orthomolecular therapy, in which you take a compound or multiple compounds that are essential to the body, like, say, magnesium, and not following the daily value that's been assigned, but to actually use doses, meaningful doses, that the body actually needs, not just to survive, but to absolutely thrive. And then all of a sudden you see the illness or diagnosis change, disappears magically. And so a lot of times I can see that it's just a matter of deficiency.
So I want to just quickly go back to something you said about
Yeah.
being on the outside when we're talking about traditional medicine versus osteopathy and nutrition and botanical medicine. Now you were saying it tends to be one sided. I believe that's exactly what you said, but along
Yes.
those lines there, um, are you referring to that on both ends of it, where the medical professional might say, you know, uh, the nutritionist or the botanical side of it is not as relevant? And also on your side, where your counterparts would be saying, listen, we can do it here and you don't need the traditional medicine. Is it reciprocated on both sides? Or you find it more on one side than the other?
If I'm to understand, I find it outside of my medical clinic.
Right.
It, it's not a two-way street. So if I ask for certain things through that patient, where I'm sharing a patient, and I ask for certain labs, or I ask for, or I want to input certain supplements, the medical, modern medicine, allopathic, pharmaceutical surgery, they scoff at it.
Right.
They go on the web and they'll look up, the minimum requirements, but they scoff at what I'm saying. Not with those I start to interact with and they start to know me, then there's no scuffing, because we get absolute brilliant results. But that's what I'm saying. But on my end, if a doctor said, like a medical doctor that's practicing modern medicine, hey, we've discovered this. This is the diagnosis. This is how we treat it. I'm like, okay, like, okay. If I'll use cancer. Cancer is a very complicated. There's so many different types, and it's pretty complicated. And you need to know. You have to have, like, in my opinion, a true depth of oncology, right? And all the different treatments. I'm not going to start telling or directing a cancer patient over the directions of their oncologist or their oncological team. You see what I mean? Like, I wouldn't do that. I know where my lane is. I would suggest supportive strategies, adjunctive. I know some things. I know some things specific to cancer, but I also know my lane. So I think it's more open from my side. We really recognize our lane. The law also enforces our lane, right? Because the medical doctor is holier than thou, right? It's a protected area. And there are certain things you can't even say or do because it's their right, right? So they're really protected in that way. And I totally respect that. But they I find, don't respect how much more we know in chronic care. Like they just assume they know, but they just don't have the nutritional background. They just don't have the hours and hours and hours of clinical application, right? They know how to apply a medicine. They know how to apply the medicine, but then they just leave the script running on its own. So hopefully I didn't go drift too much on that, but
Yeah, no,
yeah,
that's okay.
that's
I just find it so interesting because I see that myself, where in the medical profession, they might shun somebody's opinion who's not theirs. And I just wanted to know if it was reciprocated on your end, where you know, doctors of botanical medicine or osteopathy or a clinical nutritionist, let's say, might say the same thing about a medical professional and say, "Listen, I can help you. What they're doing, is not really valid." But from what I'm understanding, I think you're saying that it's a little bit more on their side. But
y- yes,
I think as time goes
actually.
on, though, I think as time goes on, you correct me if I'm wrong, but I'm starting to see, and it may be because of we have a lot more room to speak on the internet and through all these various channels now, where this information is, you know, becoming public, where before people would have to read it in some type of medical journal or something like that. So I think it's just more available now, and I think there's. You can correct me if I'm wrong again, but I think there's starting to be a little bit more synergy. In your very clinic, you work with medical doctors.
Oh, yeah, like there's I'm fortunate, I'm blessed with the group of doctors that I work with. So respectful. And I know, a couple of years ago when they would ask me questions, I thought they were questioning me. But and then I get my how do you say that? The hair on my neck up or whatever, right?
Yeah,
They
you
weren't
become
questioning me.
defensive.
Yes, they were. One person stopped me at one point and said, "Samira, just so you know, like we're asking because we don't know." And I was like, "Oh, okay." So like I'm the expert. Okay, So years ago, and it was actually one of the doctors mentored me closely and was like, "Listen, we're all human, and you know what you know. I know what I know. You know what you know. You're always really respectful of that lane." He said, "But when you know better, you need to say it. That's why you're here. That's the only reason you're here is because you're generally not afraid to say it. And I know you always back up your stuff. Like like I go overkill where I would do like reports and stuff and they were like, Samir, you need to chill. Like you don't have to, soap notes, like when you're writing your notes after, I'd have like references and citations and I'd come home and my wife would be like, what are you working on? Like, you've already been at work all day. I'm like, oh, I'm just working on my notes. And then they had to finally pull me aside and be like, you need to chill. Your work's good. We trust you. The people trust you. The results, we're getting the results. It's all good.
Yeah,
And
and I
so,
think that's the most important thing is the results, because
oh yeah,
a lot of things that you might suggest might be contradicting what they were taught or believe, and then
all the
at the
time.
end of the day, it's the results that matter, right?
Yeah. Which is again, bring me back to the subject of like really specific protocols. It's, it- it's just mind blowing that these protocols are not followed by regular medicine. Like hopefully we'll cover anemia, being anemic, low iron deficiency. um, some of these are like they're huge and there's a lot of chronic disease around it. And then I come in, humble me, I just look at the blood work, I look at their food journal, I look at their history, and I'm like, okay, this is an obvious deficiency, but the doctors are using like stuff from the 1960s. They didn't dig deep into orthomolecular application. And what I do is I chase orthomolecular application via doctors. So the doctor was a medical doctor and they're from the 1900s all the way to the 1950s, 60s, and they found a protocol with what's his name, Linus Pauling, or there's different names out there. Dr. Seelig. These are medical doctors that were like, okay, enough's enough. Here's magnesium. These are all the symptoms that this person is having. We're calling it this disease and problems with arrhythmia, their heart rhythm and, heart dysfunction. They're missing magnesium. And so they would input magnesium and the disease goes away. So, but there's just no money in that. Not to sound conspiratorial, but there's just absolutely no money. If you can go to your grocery store, corner store, and there's enough stuff on the internet and you pick up the supplement. It's just that most people don't realize it can be that powerful when you apply the right form and the right amount, right?
Well, having said that, why don't we jump into some of these topics then? So let's keep the main topic based around vitamins and minerals. Fair enough?
Yep.
Okay.
Fair.
And then let's jump into a few specific either diseases or or diagnosis that people get that you can again, so between botanical medicine and osteopathy, you clearly stated that a lot of it is to treat and manage the source of these problems. Is that correct so far?
On my part is
Yeah.
to correct the source of the problem, not treat the symptoms. Initially, I'll treat the symptoms. If
Right.
you have a cough, I might have a herb or some method to treat the cough, but then I want to know why you have the cough and get you off whatever treatment I have to help you with the symptoms. You
Okay.
get what I mean? Yeah.
So I think I'm going to pick a topic if that's okay with you,
Sure.
and then have you go into that. So one topic that we talked about last time, and maybe since we're talking about vitamins and minerals, diabetes.
Yeah.
So I'm just going
Okay.
to throw that word out there for you. I have a couple of them here,
Yeah.
and
Okay.
and
Diabetes is
specifically,
a good one.
yeah, specifically on vitamins and minerals. Okay, let's get into a topic. Let's get into a discussion on diabetes because it's pretty common thing. A lot of people have it. I think there's a lot of misunderstanding around it and the different types of it. And before we even get into that on diabetes, you probably know this, um, but I also find it very interesting that the person who discovered, or one of the people who discovered insulin, is from right here in our area.
Canadian, you got it. You
Yeah,
got it.
just right here in the area. So anyway, that's interesting. But yeah, let's get into vitamins and minerals and diabetes and how they can
Okay.
work together.
Well, magnesium right now is a really hot topic. And on the influencer thing, you'll see they'll constantly quote 300 to 600 enzymatic actions. And you're like, what the hell does enzymatic actions mean? What does that mean? It does a lot of stuff. You can reduce magnesium to what we call a signaler. It signals. And magnesium comes. So when you see magnesium oxide, magnesium citrate, magnesium glycinate, that's just the salt or the piece that's attached to the magnesium so it can travel through your system. And depending on the attachment to the magnesium will determine how much you absorb and to what tissue. When it comes to diabetes, when I'm doing RBC magnesium, so that's when I don't look at magnesium in the blood, I look at magnesium in the cell. And that's not a free lab. You got to pay for that lab. But I think it's worth it because diabetics that I test for RBC are always low. They're always low. So the first thing that you notice about metabolism, how the thyroid works, how we metabolize glucose or sugar, how we move it, how we break it down, how we store it, how insulin rises and lowers, it's all connected to magnesium. Now, I'm going to ask you a question. Have you ever heard that?
I personally haven't, and I don't have much experience with diabetes because I'm not diabetic. But
Right.
just in general conversations, no, I did have. I mean, my dad was diabetic, and my sister was diabetic, and she ultimately passed away from complications of diabetes
Right.
at the young age of 54. But
Wow.
no, I have never heard of magnesium and how it's related to diabetes.
And that's what the challenge is. The problem is this should be a known factor where diabetics are going to be low in magnesium and they're going to be high in calcium, right? So calcium gets dysregulated. So I want you to think of not as a villain, but there's a balance between magnesium and calcium. And time again in a diabetic, you're going to get stiffness, spine pain, joint degeneration, vertebral degeneration, You'll find we call them like bone rabbits, like just bits of misshapen bone, malformation of bone. This is in a diabetic. 90% of joint replacements are done to obese people or diabetics because of this dysregulation. How come this is not a known factor? And then I'll get a diabetic, and guess what they're supplementing with? Blows my mind. Calcium. They're supplementing with calcium because
Which is
someone
what
in
they
there
have too much of.
is what they have too much of, and they're stiff, right? So I will start to come in with what we call orthomolecular levels. So say you look up the daily value, and the daily intake value is 200 to 400 milligrams. Well, if you sprint, your magnesium load is up. If you are under oxidative stress, you're stressed, you have trauma, magnesium. So you actually use magnesium every day, all day. And now, say specific, hopefully, this podcast goes around the world, but specific to Canada, anyone that lives above the 33rd latitude, we're the 49th parallel, right? Our border. Anyone that lives up there, statistically, we are going to be low in magnesium and low in vitamin D3. That's just specific to where we live. So we're already low, and we can't get it from our water and our soil and our food like we once did. So even if you eat super healthy, you're not getting the magnesium that you need. You were going to say
Can
something?
I jump in here for 1 second?
Yeah, for sure.
I completely understand why we would be low in vitamin D because obviously we get it from the sun. Um, and it's not always sunny where we live in Canada.
Yep.
And, in certain parts of the world, obviously, northern part of the United States, and, we have long winters, not as much sun.
Yeah.
But how does that correlate to the magnesium? Where do we get magnesium and why are we deficient if we're, you know,
That,
I,
that's an
I'm
easy
just
one.
going to leave that with you, but why would
Yeah,
we be deficient in
be-
magnesium in this part of the
because
world?
we're low in D3. So it's called a matrix. So when you're low in D3, your body scavenges your body for magnesium, scavenges it. So if you're really low in D3, you will be really low in magnesium because you can't, if you look at your blood tests, I think it says cholecalciferol, but it goes through, it reduces, right? It becomes into this hormone. And so for it to reduce itself, it needs magnesium. So if you're already low on D3, then it's like, where's the magnesium to make this little bit of D3 transform? So you get depleted. And when you deplete magnesium, your calcium goes up. So even without you eating extra calcium, and then your magnesium will go low because there's a narrative out there where what's the saying? Milk does a body good. You know that saying or
Mhm.
commercial?
Yeah.
We push calcium on people. We push it. Got to get your calcium. And then we tell them things like get your calcium from spinach. Like we tell them crazy things. We give them food sources that the calcium, it's not transforming into what we need properly. right? So you can get magnesium from fruits and vegetables. You can get it from stuff that grows in the soil. You can get it from your meats. It's everywhere. But there's just so many factors that are preventing the absorption of magnesium that you have to supplement. I'm a true believer of what I'm saying there, based on what I see in my clinic. I do have people that transform their lives with food. They've gone the organic way. They're eating beautifully. They're really doing a fantastic job. And they still have depleted stores of magnesium. They're still deficient. So how do you explain that? Like, I know they're not, I really believe they're not lying to me. Literally, I see them like losing weight, gaining muscle. They're super healthy. Their blood work's looking great, but their magnesium is not moving enough. There's just too many factors that is going to lower their magnesium. So that's how that works. And so anywhere you go where there's no sun or the sun is less, you will find magnesium deficiency and you will find D3 deficiency, except in those that are in northern. So any type of northern people or indigenous people, any type of people that are way up at the poles that say they don't have sun for 6 months or whatever, but they eat like polar bear, they eat blubber, they eat whale, they eat all of that stuff. Their D3 is high because they get it dietarily wise, right? And there's no confounders. They're not eating processed foods and processed flours and processed sugars. So their D3 is high and their magnesium is high. Their vitamin A is high. They're getting all the minerals that they need from the organ meats, right? They're getting it from, that's if they're eating their indigenous or, their natural foods.
So if your D3 is low and your magnesium
Yep.
by default is low, that's what you said, right?
Yep.
Um, does the same work if it's the opposite? If your D3 is high, could your magnesium still be low?
Your magnesium could still be low. Because it's broken, like the signal is broken. I'm just saying that in general, when your D3 is low, I will almost automatically see low magnesium. When I see your D3 is high, I don't automatically see symptoms or deficiency of magnesium. And when I do the RBC test, they're not great, but they're not super low. So I see it one way. I don't normally see it the other way. And there's like a constellation. If I see magnesium is low, D3 is low, then I start to see that it's probably nutritional as well. And then I'll see heme iron is low, B12 is low, and then it's just through the list like that. So
So going back to the diabetes then,
yeah,
are you using the magnesium as a treatment for diabetes
yes, absolutely. I'm
and
I'm I
preventative as well?
Yes. Like, again, going back to that, magnesium has, 3 to 600 enzymatic actions. It's like it fixes a lot of things. It helps regulate glucose. It helps signal insulin. It helps with moving energy in and out of the cell. It's a really powerful compound. And so I start to introduce, because you have sleep disruption as well. I am going to speak in some generalities, but I want to make clear to the audience that I am speaking in generalities. There are specifics, but in general, I will see people with diabetes have leg cramps. They will have leg spasms. They will have restless leg syndrome. These are signs of, magnesium deficiency. And so, and they have poor circulation. Magnesium's going to open up the arteries, soften them, right? And in diabetes, the arteries, the veins, all of them start to either collapse or they tighten up and they get hard. They get hard from the outside as well, right? Stiff. And then blood pressure goes up. And So when you bring magnesium, that gets reversed. So it's an absolute treatment because you can see how many things it hits because they take medications. I can't even list you all the medications sometimes that I see to get circulation going, to water pills to get rid of water, and then I just come in humbly, like, I think you're magnesium deficient, and then they pay a small cost compared to the medication, especially if they didn't have coverage. And within a couple weeks, like some people is faster. Like some people it's incredibly fast. Within a couple days, their spasms go away. Then they stop the magnesium, their spasms come back. And that's a good thing because then they can see the connection. But on that point, I don't want to digress, but on that point, because you're diabetic, your needs are so high that the magnesium needs are really high as well. And just because it starts helping you, it doesn't mean you reduce it. You have to stockpile magnesium. You have to build up your magnesium levels. So when we get you some symptom relief, it's just symptom relief. The source of your problem is that you're magnesium depleted. So we have to build up those stores, and then we can check again in about 3 months, testing your blood. The mistake that medical doctors do is they test your serum. And it's a very small percent of magnesium that we can find in your blood in the serum. And so you make terrible calls and you're like, oh no, your magnesium's fine. No, it's not. It's not even close to fine. First off, if you've got the symptoms and you have diabetes, we already have to make some assumptions that you're depleted because you need so much magnesium. And then you're doing the wrong test. I'll do a blood test for sodium for sure. I'm going to see how much sodium. I'm not going to do a magnesium test. So that's where I run into trouble when I'm working with another doctor. If I'm asking for blood tests that they're not familiar with, then they don't want to order it because they're responsible for the findings. Or say they got audited, they have to produce the argument as to why they ordered it. And so that's a conflict too, because they actually don't know and they don't take the time to learn. Or take my offer, which is I always send a supporting request. I always send a supporting, my stuff will withstand an audit. There's a reason why I'm ordering it, and there's enough clinical support. Like I can clearly articulate why I'm ordering what it is that I'm ordering.
So I have a two-part question
Yeah.
regarding the magnesium and medical doctor specifically. So so most of these minerals and labs that the medical doctor would look at,
Mhm.
they would have a set amount that a person should have. You're too high in this, you're too low in that, whether it's cholesterol or so. When it comes to magnesium, is there a certain level that perhaps a male or female, I'm not sure if they would vary, but is there a certain level that the doctors are looking for? And if so, do they get concerned if it's too high? And in your opinion, I guess I'm asking a three-part question, but in your opinion, if it goes beyond that, is that what you're looking for?
Well, there's variables to try to answer that question. First off, depending on the lab you go to, will determine the range. So that's the first thing people don't know. So I can go to Dynacare and they have one particular range with goalposts for serum magnesium, or say they do an RBC test, a red blood cell test for magnesium, that's with a technology. So I'm not familiar with there's different ways to measure and weigh something, and they don't all use the same method. So there's different methods, there's different ranges. And then are you looking at the blood or are you looking inside the cell? So yes, we have optimal ranges, but it's going to depend on which lab you went to. In general, you're looking for the upper part of the range. You're not looking for the lower part. And then in cases specific to say like magnesium, as long as there's no contraindication to whatever medication they're taking, it's water soluble. So it's really, really hard to overdose on magnesium. Like it's super hard. You will get the runs. even with we call it pico-ionized magnesium, in which it's magnesium chloride is made into like these small particles that get into the cell instead of osmotic, like instead of you flushing it out and getting diarrhea. But yeah, so I don't have, uh, not to say I'm no concern at all. I'd just be really surprised if someone didn't know they were taking too much magnesium because you wouldn't get off the toilet. So yeah, I've never run into that. Like since poison control came into Canada, there's no one that died of magnesium.
But
Like there's
would a
just,
medical doctor push back if the magnesium levels were too high?
yeah, if it went past the reference range because they don't have, they don't understand what's an optimal range, right? So, and then even within optimal range, um, that can differ depending on who you're working with and how you're measuring it. So yeah, there can be pushback. The pushback, I don't get pushback on that. I get pushback on D3 because doctors specifically. So I get specific pushback on D3 dosing because their understanding is that the threshold, the maximum threshold for D3 is 2000 IUs. Now, let's see.
You're talking about
10,000.
you're talking about taking, like ingesting 2,000 IUs per day as a supplement?
Yeah, and blood work. So I'm going to
Okay, in the
answer your
blood.
question. I can't answer it with magnesium because it doesn't really happen, but it does happen. The pushback does happen and still happens with D3 particularly because they are so misinformed. I apologize for saying that, but it's the truth. They are so misinformed on D3. They think that it can be like even on the lab it says toxicity, like toxic levels. That's crazy talk. That's no one died. It's just literally, did you know? I'm going to go off on a little rant. Give me a minute for this, okay?
Yeah, go ahead.
The more fat on the body, opposite to how they think, the more fat on the body, the higher your BMI, the more obese you are, the more reduced in D3 you are. Every time. So if your fat soluble fat toxicity thing was true, then obese people would be just like dying, falling over with D3 toxicity. And it's certainly not happening. The complete opposite is happening. Now they've done meta-analysis 3 times in which D3 was undercalculated by 11 times, which means I've had people go to one lab, okay? And they go to the lab and the lab says 180, okay? And that's toxic on that lab. Yet you can go to the lab beside and it goes to 250. So which one is it? Are you toxic at 180 or are you toxic at 250? So depending on which lab you went to, the medical doctor will look at your lab, see that it's gone in the red, and see that that's considered toxic. It's 500 millimoles. So the actual range, healthy range, where you can navigate no issues, is upwards of 500 on a scale, right? The highest I've seen on a lab is 250. So the doctors push back and they're freaking out. They're scaring the patient, saying these are toxic levels. You have to immediately stop. And cessation happens, like they stop the D3. And then I have been fortunate where they get a rec 4 weeks later. They pay for the D3 and it's plummeted. So it was terrible advice, right? So yeah, that's the major pushback is we call it physiologic, where it's above and usually done by supplements. So 250 would be that level where I would ask someone to cut back just to kind of fit with, it just depends who I'm working with, right? But to fit within, proper standards, I know 250, if audited, would be acceptable because that's what the lab goes to, and 250 is reasonable. And the same thing is with B12. I get pushback. I get freakouts. Your B12's too high, and as soon as it goes over 1,000, everyone's losing their mind. but
I
like
would imagine
magnesium.
with vitamin D that you can reach those levels, somebody just enjoying a day in the sun. Am I wrong?
Well, yes, we have a shutoff. So, in general, for all human beings, you have a maximum of 20,000 IUs. So, we all have 20,000 IUs in general cutoff. And once the body produces 20,000 IUs, so first off, let's recognize that we can make way more than the pitiful 2,000 IUs that they tell people is the max. You yourself can produce 20,000 IUs per day in the sun, and you either burn or you tan. And then you have the shut off, and your body says, okay, 20,000, that's good. You go to bed, rinse and repeat. We have been doing this for 5,000 years, or however long the human race has been around, right? So we have a natural shut off, but the measured amount of production that we have, how do you explain then that everyone is losing their mind when I say, okay, you are D3 depleted, you're under 70, you have all these symptoms, low testosterone, low energy, or low estrogen, low hormones. You don't feel good. You're not happy. There's a reason why we call it the sunshine vitamin. And so I say take 10,000 IUs per day. And you're like, blown away because I said 10,000 IU. And I'm like, that's only half of what you can produce. So again, I'm not even close to what you yourself can produce. And trust me, you're not in Canada anyways, you're not producing 20,000 IUs a day, unfortunately, right? And of course, with the 10,000 IUs a day, you have 450 micrograms of K2. We wait 90 days. We retest you 90 to 120 days. And we try to get you out of the pits. And then as soon as I get you to 150, then I reduce you from 10,000 IU to 7,500 IU until
I think if I went into my medical doctor and told him I was taking 7, 8, 10,000 IU of vitamin D or D3 daily, I think he would first, before saying anything, I think he would check my temperature to make sure I wasn't hallucinating. Uh, I think that's
I
what would happen.
I I want to see something, just the calculation here. Just give me a second. So 10,000 IU is, let me just see if I remember this correctly. I'm just checking a measurement, and there is yeah, okay, cool. I was right. I was just figuring out. So 10,000 IUs is 250 micrograms. Like, why don't we all just start cracking up, right? Like micrograms, not even milligrams. So they scare you. They
Which again,
freak
going
you
back to
out.
the sun, you could probably get that in a few minutes, I would imagine.
10,000 IU. No, I mean, you're going to be in the sun for a couple hours, but yeah, like a couple hours in the sun, yeah, you're producing that pill. So when there was, I'm just trying to remember, there is a story, and it was timed with pharmaceutical appropriation of D3. And at that time, they were giving people D2, which is plant based, which is pretty much useless for us, and has to convert into D3. And so as soon as the pharmaceutical excuse me, as soon as the pharmaceutical companies got in on vitamins and minerals, magically it changed from micrograms to IUs, international units. So there is a story there. I know I've read it in one of the I can't remember the doctors. There's two doctors from Brazil that run D3 clinics. And that's where I'm pretty sure I read about there's some kind of history. And then all of a sudden, once it became pharmaceutical, we measured it in IUs. So if I said, do you know what a milligram is? And you're like, yeah. And I said, well, it's a microgram. It's not even a milligram. So 10,000 IUs, you hear thousands, all of a sudden just gets reduced to 250. All of a sudden, don't I sound more reasonable?
Yeah,
You know what I'm saying?
sure.
So there's tactics like that. So 10,000 IUs is not a
1,000
lot.
pennies sounds a lot too, right?
And and here's the other thing though. So that's an orthomolecular approach, right? And like, so now that we've done the math, you can see if you yourself can produce 20,000 and the highest I will go is 10,000, half, why is everyone freaking out? It's just they're just not educated to know, right? Like they're ignorant, not ignorant as in rude. They're just ignorant to the fact, and it scares them. Do you know how many people I have, prescribed them D3 10,000? They literally have a clinical issue with D3. They literally have the list of D3 deficiency, and they don't do it. They're scared. And then I have to like follow up with them. We have this conversation. I do the math. And then like, oh, I didn't know. They didn't know that it's 250 micrograms. They didn't know it was such a small amount. So now I
The number is
try.
intimidating.
The number is very intimidating.
Yeah.
And then the worst part is if we looked up, if we just Google aspirin, Aleve, ibuprofen, cough medicine, you're going to see tens of thousands of deaths every year. This is what most people don't know. OTC, like over the counter, right? OTC products, people are dying, right? They die. Like it's just a natural part of taking those medications. And no one says anything. There's no parades or marches in the streets. And
No, it's
yet
so
I'm
interesting
gonna.
because I've never heard that.
You can look it up. You can just go on Google, like how many deaths per year from over the counter drugs, right?
Yeah, I would
Or
imagine that would
problem.
be highly suppressed.
It is, but it's there. The statistics are there. You're not finding that with vitamin C, with magnesium again, with D3. You're not. It's just not happening. But
So
people are
let's tie
absolutely
back in.
petrified. Mhm.
Let's tie back in the magnesium and vitamin D to diabetes. Let's
Yeah.
just go back and tie that in. So are you recommending that to people after they're diabetic, or are you recommending that to people as a preventative source of the problem, like to manage? Is it to manage or to
To
treat?
manage, you can't prevent it because to prevent diabetes is food driven lifestyle. So you just got to. Diabetes is the mismanagement of glucose and insulin, and the two things that are going to mismanage glucose and insulin is intake of glucose or sugars. So I can throw D3 and magnesium at you. I can throw the book of vitamins and minerals at you to help you out and to manage. But if you don't stop putting that donut in your mouth, I can't help you. Like and so it's not really preventative for diabetes. It's to help manage diabetes. So
Okay.
I would say when I deal with diabetics, and we have plenty of diabetics, they have their hormones are out of whack and their thyroid is out of whack, which I know you need D3 and magnesium. So I just automatically layer that in. So their symptoms get better. They feel better, but I'm
So
still not.
diabetes
Yeah.
and thyroid are connected? I'm not saying physically. I mean, they're related.
Oh, okay. This is juicy. So in the lens of in the lens of the medical doctor, labels and diagnoses and specialties are separate. When I look at you in an obesetic or obese spectrum, or what I call the diabetic spectrum. So I know very clearly that the thyroid not functioning, when you're a diabetic, I'm not surprised that your thyroid is not functioning or your liver is not functioning or your kidneys. People think it's separate. When you have kidney disease, you know what I'm going to find in your chart? Dysregulation of glucose or insulin. You're going to have been diabetic. You're going to have been obese. So most diseases, actually, a lot of diseases are driven from the diabetic or obese spectrum. And obesity is a form of diabetes. It's just from the backside. So your body has all the diseases, complications, cancer, and growth, and it just doesn't show up in your blood as sugar. Or you're from the other spectrum in which you're not obese, but it shows up in your blood right away as sugar. So one person stores their sugar very efficiently, and they just keep growing and growing and growing. And the other person, they don't have that kind of threshold, and they can't store the sugar anymore, and it's in their blood. But that's going to downregulate your thyroid. You're not going to. The thyroid has a like thyroid stimulating hormone. It's like your metabolism, temperature, heart rate, fat burning, like metabolism. And when you have diabetes, it doesn't allow your thyroid to convert the hormone, the T4 to the T3. And then the T3 is doing its job around your body. So you have fatty liver. You have fatty liver because you're diabetic. You have kidney disease and crystals and gout because you're diabetic. So yeah, they're all under one spectrum. You solve the sugar, like from our first podcast, you solve the sugar problem.
Hmm.
Man, oh man, you solve a lot of problems. But we would end medicine today, almost, almost, right?
If somebody is not diabetic or has no symptoms of being
Yeah.
diabetic, their sugar regulation and glucose and everything is fine, so they're not in that spectrum. Is magnesium still one of those vitamins that you would recommend to somebody for good health? Because vitamin D, I
Absolutely.
know, is a vitamin that I would imagine most people should be taking.
Yes.
Is magnesium one of those same vitamins that you would recommend that people
Yeah.
just take for good overall health?
Yes, because it keeps your arteries soft and open. So you don't want your arteries to constrict, right? I mean, some things is just life. It's not because you're living a poor life. It's a long life, right? And you're dealing with trauma, pollution, stress, even stress from working out, like it's just life, right? So magnesium would have been this balancer. So I find, and this is personal too, like I was intaking magnesium, and I have pretty good lifestyle. I work out. I eat properly. I avoid sugar. Blah blah blah. And man, I pound the magnesium like
Oh.
I am a believer. It moves your bowels properly. Um, it regulates your sugar. That's for sure. But I used to have a sensation of stiffness. And if you ever met a guy that works on mobility, I'm your guy, right? I'm your guy. This is one of my specialties. And I had stiffness. And I don't know if I had told you this in the other podcast, but it was from oxalate load. I was intaking oxalates because at one period I had done keto, right? And so oxalates is a plant toxin, and you can get it through like dark chocolate, almond almonds, almond butters, like keto style stuff has a lot of oxalates. And I had the magnesium, the oxalates, and the calcium were all out of whack. And so I got rid of the oxalates, and I lost that hip pain that I had, but I still had a certain level of ongoing stiffness, and I just didn't understand. And so I took magnesium malate, because magnesium glycinate does have a sedative effect and does make me drowsy, sleepy, where magnesium malate is more of an energy. It works with ATP, like your actual energy in the mitochondria. And I don't know, a week, and that stiffness went away. And so I take 800 milligrams of magnesium minimum per day, and feel like a rock star. Yeah.
No, that's awesome. Is
Yep.
that so if somebody, let's take myself for example, if I were to go to my family doctor and tell him that I was taking 800, did you say milligrams
Yep. Milligrams. Yep.
daily, um, what do you think the reply would be from my family doctor? Now, obviously you don't know him, but just
Right. He'd be like, why? And why so much? Because he went on the internet and saw that it was from 200 to 400 milligrams recommended. And then he doesn't know that the actual amount of magnesium is actually not there. So I'm telling you, the pill says, it's 200 milligrams, but it's magnesium malate. So some of that weight is the malate, is the malic acid or the malate, right? Where I might be getting 600 milligrams of elemental magnesium, right? And then he's not maybe thinking that it's water soluble. And what does that mean? That means you're going to pee and poop out any excess amount of magnesium. So like, what's the problem, man? like,
Oh,
like your needs are so high. What are we now? 8 billion people in this world? Like, are you telling me that we all have the same daily values, the same requirements? No chance. There's no chance. So it's really individual. There are some people, because I come in at 400 milligrams, and I'll get back to your doctor in a second. I say 400 milligrams, that's where we're going to start. I do have people that are so sensitive that they'll have the runs for 3 days that I have to go to 200 milligrams. That's them. In my early days, I would be like, oh, we got to figure this out. And then I realized everyone is different. On average, your average person, 400 milligrams all day, and we'll work from there. But your doctor just may not have, he may have some insight that will calm the heart, will calm any arrhythmia, anything to do with the beat of your heart, the rhythm of your heart, how the portals stay open or close, pumping of the blood. You need magnesium. But yeah, he might think that's a lot because he doesn't know all of those factors.
yeah. I
So
find like a GP, a general practitioner, family doctor, some people would call them. I find that they're very textbook when it comes to looking at blood work and results. And again, I'm not speaking for all of them because obviously I don't go to all of them or know all of them.
yeah,
But I just
yeah,
I just find in my personal family doctor, family physician, and some others that people that I've talked to and their family physician, I kind of get that same mentality where they're very structured with their numbers when it comes to vitamins and minerals and just different things that they're looking at. Where somebody in your position as a doctor of botanical medicine or osteopathy, nutrition, you would look at those values and think, well, you just need more, or it's not going to harm you. Where a general practitioner, man, sometimes I don't want to be very specific, but I can tell you that my doctor sometimes has um, panic attacks when he sees some of the things that come off of my reports, and you would
right.
look at them and you'd be like, "Yeah, man, we're right there. Like that's where we
Yeah.
should be."
Well, actually, like I'll give you a doctor's reaction. So I had a patient. This is amazing. So 90 days, okay, 3 months. So he was 7.4. So diabetes technically starts at 6.5. Uh, but it starts way earlier than that. But we're just going to go with you get diagnosed, you're diabetic, 6.5 or higher. He was 7.4. Okay. He was diagnosed with fatty liver. His liver panel numbers were scary. Okay. Ultrasound was ordered. Like some serious stuff was going on. He's on medication, whatever. He heard about me. He came to see me. I said, well, I need these labs because you're not my patient. So I need you to ask your doctor. And the doctor, he had to fight with the doctor. Okay. And he only got a quarter of what I asked. But something on a side note, I've learned new ratios. I've learned like new ways to read labs with like minimal labs. It's really cool. And I can get some pretty accurate answers. So, anyways, he gets the labs. The doctor wasn't like too enthralled. Same thing. I was like 10,000. His D3 was in the pits. I'm like 10,000 IUs of vitamin D3. His B12 was like 200 something. I'm like, we got to get it to at least 500. So I'm like, bam, 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 bam. And anyways, 90 days goes by. This guy's diabetes goes into remission. 5.8. Okay. Now 5.8, if you know numbers, like is really acceptable. Like if you were diabetic one day and you're like 7.4. And 90 days later, the doctor looks. So the doctor, he was telling me about the doctor's reaction. The doctor was like elated, was actually excited, was like, how did you
How's this
do this?
possible?
How is this possible? The liver, like I had a full liver panel, which they did because he was like, had some serious numbers to the point where he had pain. Okay. Reversed. Crazy. Like crazy. This guy did exactly what I asked him to do. Like exactly. And it's not that people aren't following the program, but they're just like a lot slower. He just
Sure. They might
exactly,
cheat a little bit, and this guy followed it
yeah,
like a Bible.
like a Bible. And so the doctor said, I don't know what you're doing. Like he tried to explain. He's like, you just keep doing it. And he then ordered the things that I needed to order. So he took me seriously, right? You know, because these are the same doctors that say, vitamins, you just pee them out. Well, you don't just pee them out. We travel the world, like I said before, you know, to second and third world countries, and we're giving people iron, we're giving them vitamin A drops. Like it saves people from blindness, from anemia, from dying, from rickets. Like we travel the world on missionary type like medical journeys, and we give people not medicine all the time. The medicine we give them is vitamins and minerals, right? So that was a good reaction. I have a working doctor that's not part of our group, and this doctor is just like, yep, no problem, because they know I never ever ask for something unless it's needed. Like I'm just due diligence. I always work like I'm in an environment where I'll be audited. I think that's probably the best way. So like, some, if you go to some naturopaths or NDs, they're just like ordering every freaky blood test there is. I'm like, oh my God, like
Yeah. I
there's
would
no need
imagine
for
that
it.
it would be
Okay?
difficult for a medical doctor, general practitioner, family physician, um, to humble themselves. Okay, because that's the way I would look at it. I would imagine it would be difficult for them to humble themselves to be able to say, this is not what I would say or suggest or have been taught, but I'm willing to experiment with it if some other professional is guiding you in that direction. I think that's a big humbling experience for them.
It is. It's one of the difficult, like I was saying, it's a challenge. But I think what's changing is the results are so dramatic. Like what we are getting is, we don't use the word cure, so to speak. We just say remission. So we are getting consistent remission of whatever diagnosis they've been given, or post treatment for certain situations. The healing is like very quick. It's very responsive. And so those doctors are now actually preemptively ordering labs, which they would never order. So I'll get blood work, and there's like a stock standard. I'm sure you know that already. It's like kind of a stock standard thing they order, and it's not really super helpful. Like not if we're looking at your metabolic health, right? But it's safe. It's a safe way to order. And then because remember, any physician that orders a lab is responsible for the results. And that's what people don't get. So as soon as so the requisition, whoever signs off on that requisition is responsible. And they don't want to be necessarily responsible for something they don't know how to read. You
Mhm.
see what I mean? So
Yeah,
it
that
always
makes
comes
sense.
down to that, which if they did humble themselves and they did say, well, I'm working with a circle of care, they vetted, this person as a delegate, and there's no question as to that person's background and skill. There's no issue. There's tons of clinics that you can go to that have a team. It's a team. And listen, there's stuff that I get. It's beyond me. I'm just like, I don't even know what I'm looking at, right? And I'll be the first to poke my head out and be like, "Hey, can you
Mhm.
take a look at this?" Like, uh, it, I have no problem doing that. Like I really know how to stay within my lane. And when there's an acute situation that needs an acute reaction based on a particular medication or a procedure that just occurred, like I'm not giving you advice on vitamin C, man. Like I get it. And right away, I'm just like, you need to look at this. What do you think? What should be the next step?
You're talking about the medical doctors in your clinic. Our sponsor for today's episode comes from Audrey Souza, a licensed insurance advisor dedicated to helping families stay financially supported through life's toughest moments. From life and critical illness insurance to long-term financial protection, Audrey works with clients across Toronto and Southern Ontario to create personalized plans that bring peace of mind today and security tomorrow. You can learn more by reaching out on Instagram at Audrey Souza Insurance or by email at audrey.souza@dfsin.ca. That's audrey.souza@dfsin.ca, because your family's future deserves more than what ifs.
Yeah.
Right.
Yeah. Like I defer immediately. I mean, the team that I work with, they have so much trust in me, and they know that I'm very discerning of, okay, this is starting to get into an area, and I defer right away. I'm like, I think you should look at this. If you think I can still manage this or should manage this, I will. But this came up. Can you look at it? And so it's like open. And then in our clinic, which it's not the norm, they're very open about, you know what? Like one of the nurses had just done it the other day. They're like, why do you think the doctor would supplement with these, blah, blah. And we were having a discussion, so we're really like open, and that's a hard fought environment to have. It's not, I do not think it's the norm to be humble to each other when you need to be like, I don't know, or question. I think we should all question ourselves, like even with all the stuff I said, I'm emphatic, I'm excited. Uh, but I want to make sure you understand too. I'm not just like throwing magnesium or D3 or just like take as many as you want. I'm just saying that most of the time doctors are overreacting. The medical doctors are overreacting at the recommended amount because they lack knowledge. They think it's toxic, but have no problem telling you to take 2 ibuprofen a day or take ibuprofen as needed and just sabotaging your liver. So make it make sense to me, right? Make it make sense that they're over medicating at times with brutal side effects, but they're worried about me and my 10,000 IU of D3. Or like, I guess you don't want to hear about the guy that has to take 1,600 milligrams of magnesium a day, right? He's a severe diabetic. They gave him Restorelax, Lactulose, Senecot. They told him eat fiber. Terrible idea. He did everything he was told. Everything. Could not have a bowel movement. Got sent to me, last resort. I was the last resort. What did I say? Severe diabetic, can't poop, you're missing magnesium. And I think he hadn't pooped in a week or 2 weeks.
Wow.
Like it was bad, like impacted. And yeah, he went to the bathroom. Who knew? It was magnesium. It wasn't his list of medications. There were some medications there I hadn't even heard of. I had to look them up. But I solved it with 1,600 milligrams of magnesium. Can I get an amen?
So yeah, amen to that. When you have a patient that's come to you with issues revolving around diabetes, those are the two things that you would automatically look at, is magnesium and the vitamin D3.
Automatically, yeah. And time again, that's if I can get an RBC test. Sometimes, there's just not, you got to do some hoops to order certain things. So sometimes it's just so in your face. I'm just like, okay, this is like the worst thing is that they will have diarrhea. That's the worst thing. So I'd rather err on giving them too much than not enough. And like I said, I just haven't hit anyone that was like had a problem with me telling him to have magnesium. But definitely, you're diabetic. I'm giving you D3, K2, magnesium. We call that the matrix. I hit the matrix right away. Right away.
And
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 then,
too much magnesium doesn't affect anything else in the body, in your opinion? Kidneys, anything else?
well, what you're going to see is renal function. And if someone has, that's a great question, by the way. So, yes, I take that in consideration. So if they have severe, debilitating um, kidney disease, they're working off of one kidney, then yes, the conversation might be different. But see, I've taken that into account automatically. But even with people, well, not with renal failure, but even people with kidney issues, kidney disease, so to speak, that whole thing is overblown as well. They're able to excrete magnesium. Like they are able to do that. There's some things that they can't, but it's not really magnesium. Like I said, clinically, with because remember, kidney disease, you're going to find kidney disease in diabetics. Like the nephrons, like the deep innards of the kidneys get glycated or sticky. That's diabetes, but they're told, oh, you have kidney disease and diabetes. And when I look at them, I'm like, you have diabetes. That's why you have kidney disease. Like it's
Right.
not two separate things. But yeah,
Does it
they
make
can clear magnesium.
does it make a difference if you take it with zinc?
Magnesium, it you want to take them separately. So they will compete the same with copper. So I always separate magnesium from like if you have something to do with calcium, I separate it if you're eating dairy or whatever. And then if you have zinc, I would take it. It either comes with copper, or if you're taking high doses of zinc, I would separate it. But I would separate magnesium from zinc.
Okay. Um, I'd like to get into a couple of different things, but before we jump
Mhm.
into some other like clinical stories and protocols,
Yeah,
food, fasting, and nutrition. Okay. I want to just do a quick, I don't want to get into too much depth on these topics. I want to do like a fast fire, just
yeah.
a real quick. We can call it myth or medicine. We can call it healer or hoax. Uh,
Okay.
fat or fantastic, whatever we want to label it. But I'm going to throw out a word, and you just tell me quickly: is it a boom or bust? Okay, is it a healer or hoax? Okay, and we don't have to dive too deep into it. Just a fun little exercise I want to do, because there's always these topics that people have that are, yeah, there's so much controversy around certain
Yeah.
minerals or foods or whatever it is. So I'm going to throw it out. You have no idea what's coming at you,
I'm
but you
nervous.
just
I'm
tell me,
nervous.
yeah, you just tell me healer or hoax. Give me a quick little,
Healer or
and we'll
hoax?
go to the next one. Number one, creatine. Healer or hoax?
Healer. Yes. It's yes. Mitochondrial energy. Lots of good literature for dementia, like dementia prevention. Healer. Yes.
Quick pushback on that. If someone's taking creatine and their creatinine levels elevate, is that a sign of it's going wrong? Is that just
Nope.
what happens there?
Well, it's because you're supplementing, so your creatinine levels will go up. So I don't panic as long as kidney function, EGFR, as long as your kidney filtration is normal to like in an optimal range. And then I will ask you, I will say, are you taking creatine? So no, it's not a sign of toxicity. No.
Okay. Next one. Healer or hoax? Turmeric.
Oh yes, that's a big yes. So yeah,
It's a
curcumin.
yes, it's a healer or a hoax?
It's a healer.
It's a
It's a
healer.
healer.
Okay.
Yes, I'm a
So you
firm
like
believer.
turmeric then? Okay.
I love turmeric. Love it. It was part of my thesis in botanical medicine. Yes, it is a definite healer. It's my go-to for inflammation, and I have tons of clinical stories that would provide it as a healer.
Okay, because
Yes.
in this last little while, there's been so much hype about turmeric, supplements and all this kind of different stuff. Even cancer patients, turmeric. There's so many things
Yeah.
online about turmeric. Okay, next one, apple cider vinegar,
Healer.
healer, another
Yes.
healer. Okay, so you like?
It's
Okay,
I
go ahead.
love it because I got to see it work with continuous glucose monitors. So that was wild. So we would have people take their apple cider vinegar. You're taking it for acetic acid. So acetic acid has a property. When you take apple cider vinegar, it slows down the ability to break down carbohydrates. Isn't that wonderful? And then it
Why
bypasses
people take it
insulin.
for weight loss?
Yeah. Yeah. For
Okay,
regulation, like it's great for
yeah.
diabetics. And just in general, if you are like carb loading or have too much carbs, you take the apple cider vinegar. It has the two functions. One, it slows down the rate at which you take carbohydrates and convert it to glucose because we want to control it, and it bypasses insulin and takes about 30% of the load and puts it in your muscles. So it's got two factors, both measurable. I've seen it on glucose monitors, kind of lower that peak that people get in their sugar. So it's a big healer. Firm
Well,
believer in it.
I'm glad you tied that into diabetes or the diabetics because that's, I mean, we just spent the last whatever 45 minutes talking about that.
Yeah.
So,
Yeah, it's
so
one of my big tools. I use that when you first come to me as a diabetic. Right away, I get apple cider vinegar. The only thing I caution you about apple cider vinegar: total hoax. If it's a gummy, total hoax, does
all right.
not work.
I'm glad we
If it
differentiated that
Yes, if it looks like a candy, tastes like a candy, smells like a candy, it's a candy. Yeah,
because they are those gummy bears are all over advertising now, like your apple
hoax,
cider vinegar.
hoax,
Yeah. Okay.
garbage,
So we got one
garbage.
hoax in there. So
Yeah,
so
we
the
got a
apple
hoax.
cider vinegar in its true form is a healer.
Yep.
In a baby form of a gummy bear, it's a hoax.
No chance. No chance.
Okay. I'm
Hoax.
gonna throw
Yeah.
one more at you before we get into some food and fasting and nutrients and some
Yeah.
other clinical stories. Last one, baking soda.
Yes. Yeah, it's not a hoax. It will extend
Really?
your workouts. Yep. It's we use it in the hospital. Like when someone's going acidic, it's the fastest way to bring someone in alkalinity and lower the threshold of lactic acid. So it's actually a real thing.
I've
You
heard
don't want
people.
to.
Sorry,
Yep.
go ahead. Go ahead. Finish that.
Oh, I was just going to say you're not taking it and then eating because you're making your tummy alkaline when it has to be acidic. But yeah, it can prolong your workout for sure.
Okay, because I've heard people talk about baking soda, and maybe you could tell me again, healer or hoax. Baking soda before bed, and it helps prevent cancer.
I haven't heard it worded that way. I've heard of
Does
sodium
that go back to the
bicarb.
acidity?
Yeah. Um, yes, because I don't know about taking it at nighttime specifically. I have heard, I can't remember the author's name. I'm reading a book on sodium bicarbonate and studies of it with cancer, dealing with acidity and alkalinity. So I'll tell you more on another podcast.
Okay.
But for
No,
my
that's fair enough.
athletes, for my athletes, their lactic acid burn lowers, and their morning workouts are better. And I don't think it's placebo because I've been able to repeat it over and over and over.
Okay.
So
No, that's
not a
interesting. So
hoax. Not a
we
hoax.
we
It's
we
a
got
it's
four healers
yeah,
in
you
there. I
picked the
thought
good
I
ones.
thought one of them would be
Yeah.
a hoax somewhere in there, but
Yeah,
anyway, I
no.
just wanted to do something fun and go through some of those, topics du jour that people, it's all over online and there's so many opinions
Yep.
on them. And so, okay, uh, I'd like to move on a little bit and talk about um, cancer strategies.
Okay.
Okay. And
Yep.
you can go from there, but maybe specifically going back to things that involve food and fasting,
Yep.
nutrients, um, and that might be a little general, but
Okay. I know where to start. So in terms of cancer, and I'd have to look up my list. I think it's up to 11 hallmarks. We call them the hallmarks of cancer. Um, Cancer in its different forms needs energy, and most cancers need energy in the form of glucose and glutamine, an amino acid. So, nutritionally, what I have encountered so far in oncology, in any specialist of the highest order, I have yet to encounter any cancer treatment that definitively includes vitamins, minerals, nutrition, botanicals. That is my experience so far. Um, it is chemotherapy, radiation, or surgery. That's it. There's three methods, and no one's told what to eat, what not to eat, or they're told this will interfere with the treatment. When you input nutrients, which I
yeah.
can understand for
I was
particular
just going to jump in and say that if you're doing chemo or something,
Yes,
specifically chemo, they'll tell you things that you can't eat.
yes, yeah. In some of the sometimes it's like B vitamins in particular, but yeah. So I'm always on top of that. For contraindications, it's the first thing that I will research. And that's for everyone. That's for when you go see your medical doctor and you ask him a question, it doesn't mean he automatically knows it, but he knows where to find it. And that's that like I have a physician's desk reference, okay? And it's for supplements and nutrition. I have it for botanicals. I have it for pharmaceuticals. I have it, but I know what I'm looking for. So I can find contraindications really, really quickly. Um, but in general, again, the cancer is a proliferation of something that should not be there. The mechanism in which you have apoptosis, the cellular death, or the signal that says stop growing bigger or stop multiplying, those signals get broken. And those signals are dependent on sugar. So that's the first thing that I address for most cancers that are, if that's what they need, why would I supply it? And then they also need glutamine, right? I don't know if you've heard that. Glucose and glutamine. Have you heard that or?
Yeah, I've heard it. Yeah.
Yeah. Now, glutamine, your body makes it. So these glutamine cancer diets are BS. You can't stop glutamine. You can't starve your body. You can't have a diet glutamine. So they start to go after protein and they scare cancer patients or cancer patients that are getting treatment with lowering their protein. That's again crazy. What's the one thing holding you together that you're losing at a rapid rate usually?
Yeah, it's your
Is your
muscle.
lean muscle mass. Oh my
Yeah.
God, right? It's just going. Your lean muscle mass, you're not feeling well, you're sick, you're not energetic. And the first and only medical directive is to stop eating protein and go vegan. That's another form of insanity. If the one thing you're losing is your proteins, your lean muscle mass, and it's the one thing that can control insulin and sugar, because remember, insulin is feeding cancer. Insulin is anabolic. So cancer is thriving with high insulin. Why do you think obese people and diabetics get cancer? Because they're obese and diabetic, which brings us back to diabetic. Even though we're talking about cancer, you know how many diabetics have had cancer, have had cancer, are having cancer, potentially will have cancer, and that's the constant scare.
Is there a
So
higher number of diabetics that get cancer than someone who's not diabetic? Do you know that number? Or, like, do you know that?
I,
Is that a fact?
that's a fact. I'm pretty sure you will see
Oh,
that
that's
there's
so
a
interesting.
relationship. That's why I always call it a diabetic spectrum. Like if I say I look at 400 diabetics, I'm going to find in 400 diabetics that 50% have had some sort of joint replacement. 50% of them have had have cardiovascular disease. They'll have kidney disease. They would have had one form of cancer or another. Whether you want to blame it on a gene mutation or it's genetic, because there's all kind of theories, when it comes to cancer. But why is it in my diabetic population, I see their history. They've had some form of cancer. They had some form of kidney disease. They have some form of heart disease. It's time and time again, because one is not without the other. These are not separate things. And that's a huge argument when it's, of course, coming, with people that have cancer. They're trying to understand why. Why did they get cancer? And I think, I haven't lived it. I can only go by what I'm being told. They did I do this? Was there some way I could have prevented it? And those are hard questions, um, and I don't know the answer to that. I wouldn't pretend to know the answer. What I do know is there are statistically, if you're diabetic, you're probably going to have cancer. And that's you're probably going to have heart disease. You're probably going to have atherosclerosis. You're probably going to have fatty liver. Like, you're going to probably have dementia. These are diseases under the collection of diabetes. So I'm not surprised if you have a form of cancer if you're diabetic, because I know cancer needs glucose, glutamine, high insulin. They need a liver that doesn't clear out stuff. You don't have a good filter, and all of this lends to mitochondrial energy sluggishness, and then your defenses go down. And somewhere in there, one of those cells, the signal doesn't work anymore and it doesn't shut off. And then it's, angiogenesis, like it starts to form vessels to feed itself, and then it just grows from there. And the things that you need for that are carbohydrates. Now, just because you go on a ketogenic diet or you go on a carnivore diet doesn't mean you overcome or erase cancer, because there are some cancers that are not sensitive to glucose, so to speak. I think certain blood cancers. But in general, most cancers that show a proliferation or a tumor-like growth, that's sugar. That's a sugar-based cancer. And the mass is growing because it is being fed. And we've seen reversal and reduction of tumors when someone goes into a ketogenic state and runs off of fats and ketones. Now, you can't starve cancer. That's a myth, right? That's it's a simplistic way of looking at, say, a tumor growth. You can't literally starve it, because cancer is very, how do you say that? It's a survivor, right? Cancer is a survivor, and it's very tough. And what it will do is it'll start to adapt, and it will actually intake ketones. Now, it doesn't like taking in ketones. It doesn't like to run off of fat, but it can. And then you give it a hard time, and then it allows your own defenses to actually kick in and overcome the cancer itself or the tumor.
Well, that's interesting, because cancer is just it's one of those things that you hear so many different opinions on it. But having said that, it's very difficult to explain why young kids would get cancer. A lot of it people say is genetic. So there's so many different factors when it comes to it. But I think what you're trying to say in your analysis is that specific types of cancers manifest in certain ways.
Yes. And if we're going to go to genetics, when we see a young, healthy, which I have seen, and I don't even understand. Like, it's crushing. When you see a young child, so there was a couple close friends, and they've had children with leukemia and how do you say it? Lymphoma,
Lymphoma, yeah.
brain cancer,
Yeah.
like some pretty, and they were young. They weren't obese. They weren't like overtly sick or something, you know. And you ask yourself, why did they get it? And there is a belief that you can be prone. So you can have the genetic makeup so that if there's certain factors in place, it could be where you live. It could be asbestos. Like we don't know, right? We still don't know. Oh, and I think anyone that says they just simply know, I would question that. Like we
Hmm.
still don't quite know. But saying that, in two different cases, I was able to be involved, and the cancer went into remission. And in both cases, it wasn't looking good. And again, they came to me, kind of last ditch effort. They've tried everything, and someone said, you know, talk to this guy. He might be able to help you. And I put them on a ketogenic diet, and their cancer went into remission. Now, I'm not saying because of me and my ketogenic. I'm just saying they weren't doing well in their recovery.
And these were
And
not blood cancers.
no,
Yeah,
no,
because you mentioned earlier that blood cancers are
it's a little bit different. Yeah.
right.
That's a nuanced conversation as well. But like if we concentrate on uh, the cell that keeps growing in size and the cell that can just keep replicating, those forms of cancer where you have a proliferation of cells, or apoptosis, cellular programmed death, no longer works. I have so far found, along with treatment, when you put someone in a ketogenic state, they make it out of there. They heal. And in both cases, both boys came out of it. They weren't doing well until they switched to the ketogenic diet. There's a lot of things in there, but it's like, why would you give your cancer a hostile environment? It's already hostile. Why would you give it the raw stuff that it needs? And so epigenetics for cancer, in my opinion, would be the cancer is the gun, and it's sitting in that cell. That cancer potential is there in all of us, we'll say. It's a gun. Your life story will determine whether the trigger gets pulled. Not in a way like it's your fault, you know, like you did this to yourself. Like I don't think any 10-year-old kid that, you know, wakes up one day with a cancer, you know, it's their fault. What I'm saying is it's a combination of what they did, where they lived, what they ate, just everything. Their life was just lined up that it was enough to pull the trigger, because we ask ourselves, we have two people, they're twins, one gets cancer and one doesn't. How is
Right.
that possible? How is that possible? And we've done, if you look up twins, twin testing, you know, why is one twin obese and the other one is not? And what we start to see is that it was the environment. That's what set off. So they both have the same genes, like identical twins. They both have the identical cellular background. They both have the potential for cancer.
But let me
And so
let
they
me
get,
push back a little bit on that. If they're
yeah,
twins, wouldn't they have the same environment? Wouldn't they be in the same home and
no, no,
okay.
that's how the tests were done. So they
Oh, I see.
studied twins that were separated at birth.
Okay, that makes sense.
Yes, and that's how, and then you could see that the identical twin that lived with the obese family actually became obese. So, you know, or they became diabetic, or they got cancer. And then the other identical twin didn't get any of them. And so we started to understand that familial history, or your family history, or we try to blame it on genetics or genes. You know, we're scrambling for the answer.
Right.
I think what's definitively been proved is that environment is a huge factor as a trigger. If you live and work in a hostile environment, the potential for you to get cancer, I would think, is higher. And that's not being a medical doctor, that's being common sense. Like I'm expecting the guy that's a CEO, um, that has stress every day, he's living off coffee and 3 hours of sleep, even though he works out every day, I expect him to have a heart attack by the time he's 50 because of the environment he's in. And then the guy that's, 30 pounds overweight, doesn't exercise, but has no stress, has no heart attack, and lives till he's 80. So when people are like, well, why? How could this be? He was like healthy. They're not looking at the variables. And it's a really sensitive conversation, especially in my realm, because when it comes to cancer, like it's a scary subject for me. I've been deeply like I was very sad. I was working with a couple terminal, stage 4 cancer patients, and I mean, we all knew where it was going, and they came to me like right at the end. Uh, but I tried to help and make it as comfortable as possible, and I believe I did. I believe I was able to help with that, but I think it's a bit of a fantasy. I mean, we do have stories of remission and miracles, but when something gets staged, you're at stage 4, or we're already what's the home what's it called when you go when you're going to die? Um
No palliative care.
yeah, yeah. When you're at that stage, me telling you to take turmeric and ginger, like,
Right.
so I don't like anyone that tries to sell you a cancer cure like that. I think at that stage, if anything is going to save you, I think it will be acute care if they've come up with some sort of treatment or technology at that stage. Uh, but if you're in the beginning stages of cancer, I've literally seen reversals, where they come back 3 months later and the tumor is shrunk, the growth is
Yeah.
shrunk, or it's not even
When you
there.
Yeah, when you say that, you're not talking about you've seen reversals after they've done chemo or radiation.
Yeah, oh, I've seen reversals in initial states of growth, benign tumor growth, and
In the
it's
absence of radiation and chemo.
yes, I have
Okay.
in initial, even with like cysts and polyps, and there's I don't know if you're familiar with this, but we find growths that we don't know what it is, but we can't get to it, even with an MRI. It's just junk, literally junk inside the pelvis. And they don't really know it's a cancer. It's not a cancer. They're just like, we don't know, but
Just
we
there,
think
yeah.
it's benign. Right. And then they go on a ketogenic diet, carnivore diet, a low carb diet, avoiding sugar diet, and those growths disappear. Where did they go? Like, where did they go? Right.
Yeah.
We have, polycystic ovarian syndrome, like any proliferation or enlargement, anything that makes a cell uncontrollably grow large or multiply, I have seen in the initial stages before it's stated as malign, malignant, or it's, spreading, it's moving around, it's growing at some crazy rapid rate, or like in the initial stages where everyone's still trying to figure out what's the next best stage, what's the next best treatment. I have seen a low carb diet do wonders. I have seen that. Now in the later stages where post operatively with breast cancer. Um, and then there was some fear of some other growths or the other breast with fibrous if they didn't have both removed, or, like there's different scenarios. I've seen uh, growths reverse and what we call calcium foci, like concentrated bits of calcium disappear with iodine and selenium and cofactors. So, uh, or just quicker recovery. I've seen quicker recovery with um, breast cancer patients where I have one that's not doing anything, but I know of them in our clinic and they're just having a really hard time. And then I have someone of similar demographics that had breast cancer. They're a breast cancer survivor, but they're on our program and they're thriving as much as you can thrive after such a traumatic experience, but I can see the difference. There is a difference even in post recovery.
I'm going to give you a clinical story, let's say.
Yeah.
And I'm just going to tell you the story because I think it's interesting and somewhat perplexing. And I'm not really asking for your opinion on it, but you're more than welcome to offer it. But I just want to share this with you. So it's a personal one. So my father was diagnosed with lymphoma, and I believe it was Hodgkin's lymphoma when he was 53. Okay. There was no prior to him, my grandparents, great grandparents, or nobody really had lymphoma in the family. There was cancer in our family. I think there's cancer in most families, but there was no cancer in the family. Okay. Oh, sorry. There was no lymphoma in the family
Right.
that we knew of. Okay. So that was at 53. At 41, I was diagnosed with lymphoma. Okay. With Hodgkin's lymphoma. And at that time, because my father had previously had it many years before I did, it was about 20 years before I did. The doctors took a sample and sent it to a lab, I believe it was in Seattle, to check for any type of genetic correlation, okay, between him and I to see if there was something genetic there. The results came back. They said there's no evidence that any of it is genetic. I thought that's fine, but it's odd, also
Sure.
coincidental. And the doctor said, well, you guys have lived in the same home for many years. Could be environmental. It could be the neighborhood you live in. It could be, I don't know. We had an auto wrecker behind the house. It could have been so that, so far, it doesn't seem like too much of a wild story, right? Could be environmental. Okay. So my son, which
Yeah.
AJ, he was diagnosed at 19 also with lymphoma. And we didn't grow up in the same house he didn't grow up in the same house or neighborhood that me
Yeah.
and my dad did. I mean, I grew up with my dad in the city, in Toronto. Okay. My son was born and raised in the country around farms. Um, so still today, I'm just really perplexed that 3 generations, all male, younger and younger, all lymphoma. So when he was diagnosed, they also did blood work and sent that off to the lab to check because now it's 3 generations.
Yeah.
Still, they came back and said, we have no evidence today that there's any relation that is genetic. So I'm not looking for answers in this conversation from you. I'm
Right.
just saying it's really weird and odd, and I have a very difficult time comprehending it. They really, I mean, medical doctors have always said, or the ones that I've talked to anyway, that lymphoma is really not a genetic thing. They don't. It's not like breast cancer where they
Right.
say you have
The
breast cancer, you're
mutation.
prone to it.
Yeah.
Yeah, get checked out, etc. And we didn't have it like 2 generations. We had 3.
Right.
So it still baffles me today.
Well, your story perplexes me because I was familiar with your story. And so just so you know, I've been rolling that around in my head myself. So I'm not going to give you any answers, of course. Again, when I see something like that, I revert back to like all male, a little bit younger each time, same type of cancer. So if I'm just trying to walk through it logically, they said that it's possibly environmental. But in those cases, I always revert back to there's a common denominator. We just haven't identified it. In that you're a responder to that common denominator. So you have 3 generations. It's not, say, your genes. They couldn't find anything, right? There's
Yeah.
nothing genetic that says this is why you have it. So they couldn't find. Doesn't mean you don't have it. They just couldn't find it.
Right.
But what I would say with a little bit more confidence, and you can comment on that, is that there's also there's has to be something that you all responded to. There's something.
That makes sense to me. That's what's always in my head.
There's something. I use that
It's too
expression.
coincidental, right?
Oh, and there are no coincidences, my friend. There are no coincidences. It's in front of you. We just have to be humble enough to say we don't quite have the answer, but I think we're allowed to use a little bit of common sense. You're all from the same family. You're all male. The only changing variable is the age, right? It's happening younger, but there's common denominators. So we just haven't discovered what the common denominator is that triggered it. But something, because it has to trigger, something has to start it. Something has to start the dysfunction of a signal, right? So it's a signal that gets emitted or not emitted, and that's where the dysfunction happens, and that's where the cancer grows and spreads. So what set it off? And then again, it's not a blame game. It's your genetics just respond. We just don't know what it was. So whether you were in the country, the city, living together in the same environment, but AJ wasn't living in the same environment, but you're all reacting to something, and it might not be as rare as you think, because we're all pretty common, right? Like all of us do pretty common things every day. And so there's probably something somewhere in that life, your three lives, that you responded to, and it got triggered, right? We just don't know what it is yet. So
It's
that
a
that would be
pretty
my
interesting
guess.
case study, I think, for
It
someone in
is.
the
And
medical field who's, you know, into and interested in these type of problem solving scenarios. I think it's a very interesting one.
uh, so much, in fact, that if someone takes enough interest that has the research capabilities, y- it could be a lifesaver. Just imagine if it could be figured out what was the trigger. What day did it start? What started it? It's in these three males. We can't find a gene. We can't find a DNA piece that tells us that they all shared it, but they all got it. They all got it in the
Yeah.
same way. Were you all in to the same severity?
Um,
Like
so
in
I
terms of
was,
how long it took to be treated?
yeah. So I mean, to be honest with you, with my dad's diagnosis at that time, I wasn't very young. I was in my early 20s, but it wasn't something I wasn't attending the hospital visits with him. It was more my mom that was doing that at the time.
Yeah,
So I just saw him struggling through his chemo treatments and all of that kind of stuff. So when I was diagnosed, I was what they call a stage 2B. So between 1 and 4, obviously 4 is the worst, and A and B is how aggressive it is. So I was a B, which is the aggressive growth, and and the stage 2 when it comes to specifically lymphoma, because I think it might vary for different types of cancer. But
yeah,
I had it in my neck, my chest, um, and then AJ when he was diagnosed. I mean, he was healthy. He was competing in sports, combative sports. He was boxing, he was wrestling, he was doing jujitsu, he was competing all the time. I mean, that was his lifestyle. And he was diagnosed at 19 and he was stage 3.
right,
So he was, even more aggressive. He had it same neck, chest, and spleen. I also had my underarm. I had neck, chest, underarm. Um, he had it down and from there and then worked his way down to his spleen. So he was stage 3. So I don't know what stage my dad was, to be honest with you.
right, right. Well, that is something to hopefully someone picks that up and pursues.
Yeah. Uh,
Definitely.
like I said, when I was diagnosed, they said, well, it's not very common for it to pass down to another generation, meaning, they're looking at the genetic part of it.
Yeah.
And whatever, we kind of left it alone as environmental coincidence, whatever you want to call it. It became really bizarre when my son was diagnosed at 19. That's,
Yes.
when AJ was diagnosed, that's when it really became like, really? And then we sent
Yeah.
that blood work in again, and they're like, just at this stage, we just don't have any scientific evidence that supports his genetic. So it
Yeah.
was like, that's just like blew me. Still today, it blows me away.
Yeah. It blows my mind when you say it. Definitely, there's a common denominator. It just hasn't been identified.
Yeah.
Like that's the way I would look at it. Yeah.
So in closing, just to get off this topic, um, is there anything with vitamins, minerals, supplements that you want to share that maybe
Yes. Yes.
is related to the topics we've had, or another one altogether? I'm just going to kind of pass it over to you and let you go to town with it.
I think one of the most common um, misdiagnosed or inappropriately supplemented is iron, and I think iron is toxic, and iron builds up in your liver, and it's the number one um, problem that I see, that people are told they're anemic, or they are iron deficient. But in whatever manner it's looked at, they are told they don't have enough iron. And I think that is brutally incorrect. And there's very effective ways to test it. It just doesn't fit within the framework of most medical approaches. So if there was one kind of supplement or correction that I would make with iron supplementation is the one that I've developed, in which I do have you take iron initially, and then I wean you off the iron and I move you to copper, which you absolutely need. You need copper and you need vitamin A. And so, as our prior discussion where I said D3, magnesium, K2, diabetes, obesity, if you are told that you are anemic, if you are told that you have thyroidism or hypothyroid, anyone that has hypothyroid, that your thyroid is not working well, will generally not have iron, and vice versa. So, but it's not that you don't have enough iron, it's that your body can't do anything with the iron. And to move iron is life. Iron is oxygen, right? You cannot live without oxygen. Iron is energy. It metabolizes and moves energy and oxygen, right? So the whole medical community literally throws the kitchen sink of iron at people, throws it at them. And when I say patients are coming to me chronic, I'm talking 20 years, 30, like their whole life. Since they were teenagers, they're like old people now. And I would say, okay, let's do the math here. I'm throwing iron at you at high levels, and it never works. You do your blood test, your iron is always low. You always feel like crap. Your hair is falling out. Your skin is flaking. You want to take a nap. You got to go to bed by 6. You bruise easily. You're just a mess. So I come in. I say, okay, no problem. I look at your diet. Your diet sucks. There's no meat in it, usually. So I fix that. So as I'm fixing the protein intake, I give you a little bit of heme iron. Now, I'm not going to tell you how much because that's proprietary. So I give you heme iron, the proper iron. In the medical community, they give you plant iron, which is garbage, makes you constipated, which means the patient is not adherent. They don't follow through. And then I bring in copper. Copper makes the iron work. There's something called seroplasm. So the copper activates the iron and moves it. Almost everyone has tons of iron in them. They just don't know it. And when I do a blood test, I test if it's your medical doctor, he will test ferritin. And ferritin tells me what your storage is. But who cares what your storage is? Your storage doesn't tell me how much iron you got right now. If you and me have to run from here to the corner, I don't care what's in your storage. I care what you got right, what's in your pocket,
Yeah,
what's
what's
in
going to
your
get us
blood.
there?
Yeah, man. So they don't even check the right thing, but they check ferritin because it's cheap. It's very cheap. And someone along the way said, check the ferritin. So we make all our decisions on what I would call. So I'm trying to figure out your finances of today by checking your investments that aren't going to come to fruition for years, right? I'm looking at your long-term savings to determine how you're doing today, right? And so the iron that they check is not even the right one. The one I check is your serum iron. I check to see what's in your blood, how much cash you got on you now. And then I check the protein that moves the iron to make it happen. And then I check how much of that protein you're using, how saturated you are. So it's basically, I look at your iron and I say, what's your long-term savings? What's your cash on hand? How much credit do you have? And how much of that credit are you using? Your average doctor, and I don't know if you've run into this already, is not doing an iron study. They just do your ferritin. So I give them the heme for 30 days, and then I give them the copper, and I introduce 10,000 IUs of vitamin A. The vitamin A makes the copper work. So see, each one has a job. I have not run into a doctor yet, and I'm giving away information right now, and that's okay. It's 11 milligrams of heme iron.
That
But
intellectual property is disappearing.
it's all good. It's all good because you still need me to make it work. So, anyways, if your energy drops and you still bruise, then I know it's some iron. Like we have to keep the iron up. But if your energy doesn't change once I get you off the iron, then it proves my argument that you are never iron deficient. You were deficient in ability to move iron, to move energy and oxygen. And then that's the biggest supplemental change that I do, aside from the magnesium, the D3 and the K2, is heme, copper, and vitamin A. And then I get a lot of pushback on the vitamin A because, again, we already figured out it's 250 micrograms, right? It's 10,000 IU, and I'm well versed in orthomolecular application of vitamin A for a time and a reason. And we can cycle it on and off as needed. I just do the blood work, right? I just do the follow-up blood work. And believe me, you, sir, in some cases where it hasn't changed in 20 years, we do blood work 90 days, sometimes it takes a little bit longer. Their iron starts to move up. We're not supplementing with iron. That's the coolest thing. Their ferritin stores are getting filled up. Their iron serum is going up. Like all the things that need to go up are going up without a drop of iron after 30 days. And it's just with copper and vitamin A. And that's been huge. And then the connection between, so I'm what you call, let's see, it's like an iodine literate practitioner. So there's a lot of fear mongering with iodine. And I'm just trying to remember what it's called. There was a study on rats, and then this study on rats became like the Bible for dealing with iodine. It's literally a study on rats. And it's a phenomena where your thyroid stimulating hormone goes high, and then it's misinterpreted as iodine makes your thyroid go into hypothyroid state, right? It's like a bad thing, and it's not. So that's the other major supplement that I've done, where I implement iodine, selenium, B2, B3, um, vitamin C, magnesium. There's all these overlaps. And currently, I probably have a dozen. I have more, but like I have a dozen cases that I'm like tracking and comparing, and they've all were given Synthroid or levothyroxine, for their thyroid. Their hair is falling out. The medicine's not helping them. They're miserable. These are ladies. They're having weight problems. Their hands are freezing. They're dysregulated. Like they literally want to drive into a wall, and it's amazing. Um, over the course of 3 months and then 6 months, the one lady was losing hundreds. I asked my wife if this is a real thing. I said, when a woman tells me she's losing strands of hair and says like hundreds or 50, like, does she know actually how many strands of hair? And she's like, we do. I'm like, okay. So they, like they notice this stuff, like I'm not noticing anything, but when they comb their hair, it should be like 10, 20 strands max, like 10 strands, some hair on the bottom of the shower,
Sure.
where they're losing like 50 strands, 100 strands. And in all of those cases, we reduced from hundreds of strands over the course of months to, 100, 75. I had one lady, literally, I think she was counting them until we got down to 10 strands.
And they all came
And
they all came to you with the same iron deficient problem,
you
which
got
may
it.
or may not be iron deficiency, but that's why they came to you.
Yes. And then coincidentally, but not coincidentally, because iron is needed in the conversion. We call it a bottleneck. Iron is needed and magnesium is needed for T4 to convert to T3, right? T4. So that's the medicine. The medicine we give you is the T4. Now, here's the funny part. I can't pronounce it, so I'm not even going to try to pronounce it. But T4 in the 4 is like parts iodine, and T3 is 3. There's little like bits of iodine. So that should tell you that iodine is a good thing, and iodine is essential. And anyone that doesn't have iodine, what we find is that they have cysts. They get polycysts. They get ovarian cysts. They get uterine cysts. They get breast cancer. They start to have proliferation of cells, cellular growth in all the female tissue. So female needs are much higher um, for iodine. So yeah, they all came to me with iron deficiency. They all had symptoms of magnesium deficiency. I'd say all of them were D3 deficient. You see what I'm saying? Like there's a pattern of not disease. There's always a pattern of literally almost like malnutrition. They just don't have, like they're all
You're
low in
finding the
B12.
symptoms.
Yeah,
You're
like
discovering the symptoms.
that's it. And so I'm getting pushback there. That's probably some more pushback that I'm getting. Freaks out doctors, freaks them out as soon as you start talking about iodine. For me to set up my program, in this case, I had to do so much citation, like so much clinical referencing to cover my ass and all of us. But I mean, it's well documented. Dr. Fleckus, Dr. Brownstein, Dr. Abraham, and Canadian surgeon Dr. Gent, way Canada. So like 4 major pioneers um, that show pretty definitively that most of us are iodine deficient. I mean, even in myself, I had eye trouble in my left eye, and I was not feeling well. I swam like 3-4 times a day. I was in chlorine, right? And chlorine mimics iodine and starts to block your iodine. And then I started to find other swimmers had the same thing, but I started iodine, and my we have some receptors in the eye receptive to iodine, and you know who I'm straying all over the place. Just give me a sec. You know Judo Jean LaBelle,
Of
who
course.
that name is?
Yeah,
Yeah.
yeah. He was very
So
close with Ronda Rousey.
yeah, you got so
He was, yeah,
1997.
of
He
course.
came to Toronto with Oleg Toktarov, and
One of the
they
early
were doing.
UFC guys.
Oh yeah, and they were trying to do a
UFC
move
2
on
or 3
me.
or whatever it was.
Yeah, so this is like pioneer time, right?
Yeah.
So they were trying to do a move on me, a neck crank, and it didn't work. And I should have just tapped, but I'm just not in my right mind.
Sandman.
And so the guy's walking by and he's trying to do this move, and I'm like, it's not working. I should have just tapped. And so Judo Jean LaBelle says, "Oh, well, let me see." So he gets on top of me, and then I wake up. So what happened was he chinned me in the eye, optic nerve, and knocked me out. So he did the neck crank, stuck his chin in my eye. But ever since, this is all for the iodine story. He knocked me out, and I wept. My eye wept for about a year. It would just weep, and it was blurry. So now we fast forward from the 90s all the way to a couple years ago. Um, I was doing research. I didn't realize there was a connection between your eyesight and iodine and how your eyes work. And I started to take iodine. I learned about mimickers of iodine, like they're called halogens. And it healed. Like no fuzziness, no weird sensation. It's a hard thing to describe, but there was always something in my left eye uh, gone just from the iodine. So I
It's
would
amazing
say
what these botanicals and natural medicine can do.
it is amazing. And I know people, their criticism is this is anecdotal. This is just, but hey, when there's 100,000 of us that have the same story, you know what I mean? If we're all saying when we take turmeric, our knees feel better, well, then I think there's something to that. If we all take iodine and our hands are no more or no longer cold and we can start losing weight again and my hair stops falling out, then I'm gonna say is the iodine doing it, right? Or I've been iron deficient for how long, and then I start to add copper and vitamin A, and all of a sudden my iron changes. I don't need a double-blind, placebo-controlled trial to tell me. Just like I don't need a 60 years of science to tell me that when you smoke, it's really bad for your lungs. I seriously, but we waited. The community did not say that smoking was bad for you until the clinical trials came out. And
And
that's where,
someone's always going to throw it back at you and tell you that their uncle lived to 95 and he smoked for
yeah,
75 years.
hey, and good for your uncle. Just for the average person, right?
Yeah,
So
you
yeah,
mentioned
it's yep, go ahead.
so you mentioned when you were talking about the iron and iron
Yeah,
deficiency, you went through a few things, but you quickly mentioned breast cancer at the
yes.
same time. I'm wondering if there's a correlation of those two. And the reason I'm asking that is because I have a very good friend of mine who did have breast cancer, and now she is, I'm going to put it in air quotes, iron deficient, but she is, again, the problem with the hair, always tired, like just, nobody could really figure it out. She's been to several doctors and, obviously medical doctors, and other than injecting her through IV with iron, I mean, she's at her wit's end trying to figure this thing out. And
Well, we just solved it.
yeah,
We just solved it. So for breast cancer specifically, and the best studies, and then she could look up Dr. Gent, right? He's Canadian. But if we look at Japanese women, their breast cancer rates are very low. When we look at first generation, when we take those Japanese women and they move to California, their rates of breast cancer goes up. And then
mm,
second generation, their breast rates go up even higher.
wow,
And the only thing that we could find was the amount of seafood and seaweed eaten by the Japanese on a daily basis is approximately 9 milligrams on the low end. They're much higher. They're into double digits of milligram intake of iodine. Whenever we test biopsy or whenever we test tissue in the breast in a cancer patient, they are deficient in iodine. It's just they're not being tested anymore unless you're part of research, right? So they will have too much calcium, they will have low magnesium, they will have low vitamin C, and they will have low iodine. So iodine has an effect to re-signal apoptosis, cellular death, and slow down proliferation, growth. So now we have post-cancer, but remember, we have to go back to the iron. Iron is part of that mechanism. Iron is there's a relationship between iron, iodine, thyroid, and they will have cold hands or just their temperature will be off. They're just not regulating temperature. They'll be hot when they're not supposed to be hot. It'll almost mimic menopause, and they will become anemic, or their doctor will tell them you are iron deficient.
Mm-hmm.
And so they will be prescribed iron, and their hair will continue to fall out, and they will continue to feel miserable. So that's your first clue that you're not iron deficient, because I'm giving you iron. And then if we look at the cancer patients that I've seen, they're given a plant-based iron, which doesn't help them. So then
We're
those
talking
same
about
patients
post-cancer.
post-cancer,
Okay.
yeah,
Yep.
post-cancer, where they're now iron deficient, and they've got some thyroid issues too. In all of the cases, when you're studying breast cancer, you're going to see iron deficiency and iodine deficiency. So how did that cancer occur, or how did it grow, or how come some are more severe than others? And you're usually going to see there's going to be a nutritional deficit. And the strongest association correlation, the strongest one that we have found, and in the doctors that I named, has been iodine deficiency. If there's any cancer or growth in the breast, the ovaries, the uterus, we see that they're low in iodine. They don't have any intake of iodine. And then when we introduce iodine, we start to see a reversal of growth. I'm not saying we can reverse breast cancer, but if you look up Dr. Gent's research, you will see that there was
Is he out
a
of Florida?
no,
Or is
Dr.
that
Gent.
Canadian?
He's Canadian.
Canadian.
Yes,
Okay.
yeah, we gotta be proud of our boys.
Yeah.
Yeah, yeah. So it's literature that's been around for a long time. I refer to those guys as the hive mind. So I've applied, like Dr. Fleckas, who's from the States. They have like clinical protocols. So I learned their clinical protocols, and then I started to apply their clinical protocols. And then I took an interest in breast cancer, and I'm not quoting them properly, but first the breasts, you just don't wake up and then it's like breast cancer. Like there's stages. And what they noticed was anecdotally when we're working with breast cancer survivors, there was fibrous material that had started, very, very small fibrous material that was ignored. It was ignored because the doctor said, this is fine. That was not malignant. It was not, it was benign. It's just, but there's stages, and then the tissue gets more fibrous, and then it starts to grow, and then it gets, in the ultrasound. And what they found when they catch it at that point, and now I don't have that many patients, 2 ladies. I'm waiting for I think just 2 or 3, so I don't have a large enough load because I had to wait till they redid their ultrasound. So some were set for like 3 months, others were set for 6 months. You've got some growth here. We're not too concerned, but we will retest in 6 months. And so what I did was I put them on a very aggressive iodine protocol, and now the two, I'm still waiting for that third. The two, their fibroids have reduced. So just like the clinical literature said it should. And I had to track them. It's like my career's at stake here, but I had to track them very closely. But I mean, it's really scary for me. It's very intimidating. I don't want to play with anyone's life here. I want to help them, right? So I always caution them. Do what your doctor said. Like follow his directions. Like a disclaimer, right? Like there's no guarantee, but I'm sure in a couple more years I'll have just as many patients as Dr. Fleckus and Dr. Brownstein and Dr. Abraham had, in which they saw a reduction. I have one lady that was post, and she went on the same protocol, and we had another lady that didn't do the protocol, and I think, like I was saying, she just bounced back from a very aggressive breast cancer. She just bounced back on this protocol. She was like all for it. So that's my take on iodine and breast cancer and any female tissue. So if you send her to me, I'd take care of her.
I'm definitely gonna talk to her about it for sure,
Yeah,
because we've had conversations, her and I, about this specifically,
yeah,
and her looking for alternatives because she just wasn't getting the results that she wanted through her, the doctor that she was dealing with.
right, right.
And they looked at a couple of different things and they tried different things, and she's been going at this for a few years now, and she's just always tired, and she says it's just beating
Yeah.
her up. And
Well, it's
and
not
it,
an iron. It's not an iron deficiency. If she's already gone the route of iron, and we've given you iron, and it doesn't change it, well, then you're not deficient because I just put it in you. Especially too if she had intravenous. If you get an intravenous iron, you go get the IV,
yeah,
and you feel great for like say 2 days or 3 days, or maybe you don't, and then that's quickly goes away. Well, then you're not iron deficient. I just pumped you full of iron. You're not iron deficient. You have an inability to move iron. It's that straightforward. And
mm,
then it's unfortunate that it just hasn't been explained to her. Like, you can't move iron without copper. Period. You can't do it. Like, if you can find a way, you show me, and I will come and take your class. But there's no way you can move iron without copper, and you can't activate copper to its full potential without vitamin A. And this again is orthomolecular osteopathic medicine of treating anemia, or treating low iron.
yeah. The beautiful part about these conversations is that somebody, hopefully more than just somebody, but somebody is going to get value in them. And that's,
I
I
hope
mean,
so.
if we can help somebody, I mean, that's the main thing, right? So here's one thing that completely off of medicine.
Yep.
I mean, we've been talking for a little while now, but completely off of medicine. After our first chat, the one
Yep.
thing, again, nothing to do with medicine. The one comment that I was getting, okay,
Yep.
and up until recently, I mean, it was a couple months ago that we did the first show.
Yep.
I can't tell you how many people, and I could see it now because I said, where are you getting this from? I could see it now. And as soon as I tell you, you're probably going to say, I get it a little bit. I can't tell you how many people said to me, is Samir your brother?
Yeah.
They're like, you guys look the same. Are you guys
I
brothers?
got that too. I got that
Yeah.
too.
Yeah.
Yeah.
So many. I've had people say to me, I know your family and he looks more like your brother than your brother.
Well, that's it.
So,
Albano, you're my brother. That's it. It's
well, yeah,
official.
it was just, when somebody said it to me, I'm like, yeah, I guess. I've had multiple people say that to me.
Well, you
So
even got the dart.
same whiskers. Yeah. Same
Yeah.
hairline,
Just
same whiskers.
just just different fight record.
Yeah. Yeah. So I just thought that was pretty interesting. I wanted to end on that. And since you mentioned Jean LaBelle, I'm gonna end on this.
Yep.
Jean LaBelle, obviously he was very close with Ronda Rousey. It's pretty well documented. I mean, even when she was in her prime, there was many times where there was clips of her and Gene, and she was talking to Gene. I think when she was the coach on The Ultimate Fighter, if I'm not mistaken, Gene LaBelle, she brought in Gene. But um, you heard that she's going to be
Coming
doing
back.
what's that?
She's coming back.
Yeah, she's coming back for the one fight
Yeah.
against Gina Carano.
Yeah. Yeah.
Yeah, they're. I mean, I don't know. It's. I mean, they're obviously both. Neither one of them has fought in a few years, and they're
Yeah.
probably not in. They would probably have to do a really good camp to get in fight condition because I don't think they're in. You know, that that shape to be fighting. So I think it would
Yeah.
take them a little while. But me as a fight fan, I just think it'll be a fun fight.
I think so too. I think,
You know,
yeah.
it'll just be a fun fight. That would be my take on it. Just a fun
Yeah.
fight.
I think it'll be just interesting, especially for Rousey, because she's gone through some hard times. I think mentally, for her to come back, it's probably something that she needs. More so than Carano. I think
Yeah,
psychologically. Who was it? Home? Who
Holly
was the
Holmes.
kickbox? Yeah, Holly Holmes.
Yeah.
Um, he's just coming back from stuff like that. I think.
Well,
This might help her.
yeah, I mean, she lost pretty bad to Holly Holm, and then she came back against Amanda Nunes, and then I think it was even worse than the Holly Holm fight. So, yeah,
It'll be
it'll,
interesting.
it'll be interesting.
Yeah.
Again, I
Yeah.
think they're both way beyond their prime. They haven't been active, either one of them. Um, I think it's more of an honor thing that they were talking about. I think Rhonda said if she ever came back to fight somebody, it would be Gina because Gina's the one that really, at the end of the day, she's the one that paved the way for women's MMA. You
Yeah.
know,
Yeah.
I
Yeah.
think you have to be a real fight fan to know who Gina Carano is. I remember Gina Carano before she really became an MMA fighter, and I remember her on a TV show in a Muay Thai competition. I don't know if you ever saw it. I don't even know what it's called. This was before people knew who Gina Carano was, but I bet you could
Right.
YouTube it.
Right.
There was one of these reality shows, and they took a bunch of female fighters and they went to Thailand and they competed. So I think they were all American, and they competed against some female Thai fighters. And Gina Carano was on that show, and that was my first connection with Gina Carano before MMA and what she was doing there.
Yeah. Huh. I don't
So
remember that. I would end on this in you got to know when it's time to end the career. And I have to give a personal shout out to my wife, Lisa. She said, I will support you. And she did through all my fights. She, helped me. She always made sure I was fat. She just did everything you would want. And she said, but the day you retire, the day you decide you retire, you're not going to be like all these other fighters that don't know when it's time to retire. They retire and then
yeah,
they come back for the comeback fight. She said, or we're done. That's my only. So you fight as long as you want to fight. I will be by your side. You fight as long as you want. I will never ask you to quit. But the day you quit, you're done. And I'm so glad that she held me to that because I couldn't tell you how many times after 2008, I was like, you know what? Maybe I'll just have one more. Maybe I'll just
you
have
get the
one
itch.
more, right? And people would ask me, hey, why don't you just come back for one more? And I was like, no, I ended on a high. I'm good. And I never went back. And so I don't have to go through what I see. We have memories of all these fighters that come back and then they get knocked out and it's a mess. So I'm glad
Yeah.
I ended on a high. That's what I would
If
say
I
to
had
that.
if I had to go back, everyone compares in boxing you'll get all these simulations, who's the best boxer? Was it,
Yeah. Yeah.
Marciano against Muhammad Ali, whatever. If I had to do an MMA scenario in my head of a dream fight that never happened,
Yeah.
that both of them are retired, this would have been my dream MMA fight of these two in their prime, GSP and Khabib.
Ooh. Yeah, that
I
would
mean,
be
they talked
nice.
about it several times, but that would have been my like that would have been my dream fight to watch.
Yeah,
GSP
that would be
versus
good.
Khabib. Not today. I mean, they're both
Yeah.
they're both, but if I could have both of those two in their prime at that time, that would have been my
That would have been a good one.
that would have been, it just would have been an interesting fight to watch to see who could impose their will on each other, or
Yeah,
which one of
yeah.
them could impose their will on the other one.
That would be very, very interesting.
So,
But that's
and they're
like,
good friends.
oh, are they good friends?
Yeah, they're good friends. Yeah, they have a lot of
Oh, that's
mutual
cool.
respect for each other. Yeah.
Yeah. Oh, that's cool. I was gonna say I would like to see. I don't think it happened. Fedor and Couture.
Yeah, at that time, yeah.
Yeah, something like that. If he had been in the
Fedor
UFC.
was the man
Fedor.
at the time
Fedor.
who
Yeah.
yeah, he never made it to, I don't think he ever wanted to fight in the UFC,
Yeah.
and, so they just kinda couldn't cross paths at that time, but you're right,
Yeah.
because Randy Couture at that time, he was, I think so the last time we talked about who we thought was the most influential in making MMA what it is, and we both
GSP. Yeah.
agreed GSP. But I think Randy is up there in that conversation because even though he came from
Yeah.
that wrestling Greco-Roman style, you know, he started manipulating people in different ways, whether it was manipulating them and striking and just being able to impose his will. And
His
I think
will.
he was
Yeah.
another one of those early people to kind of, you know, have that high MMA IQ.
Yes, absolutely. Integrating all the ranges, like learning. He was willing to learn and add to his game, his repertoire.
Yeah, I remember
Definitely.
watching him when he fought Tim Sylvia, and he just went into boxing mode, and he was slipping and ducking and weaving and footwork, and I'm thinking, where did this guy come from?
Yeah. Yeah.
He was just able to adapt. So he was just another one of those guys that was able to truly make MMA,
Yeah.
you know,
Yeah.
as
Yeah.
opposed to being one-sided.
These are the pioneers. These are the pioneers. Good memories. Good memories.
Yeah, absolutely. Okay, listen,
All right.
thank you very much. That was an awesome conversation. I'm sure a lot of people will get a lot out of it, and we'll do it again.
Awesome. Thank you again for this opportunity. I think what you're doing is amazing, and hopefully we can just keep reaching out to people and listening to their stories. I was able to go back and start to listen to more of the stories and your story too, and I think there's a lot of lessons there. So I would encourage anyone watching this podcast to actually watch the other ones that you have on the channel already. Okay.
Absolutely. Thank you so much.
All right. Okay.
All right.
I will talk to you soon.
All right. Thanks.
My brother. My brother.
Yeah, brothers. Yeah, that's
Okay.
right.
Take care.
All right. Okay, bye.